So, good evening, everyone. I am Raksha Joshi from Glenmark. Today, we are here for the last and final session of Beat Basics and Advanced Studio Techniques. I'm very happy to be here and very thrilled that you all have been attending the session, all the 6 sessions throughout. And let us go ahead for the final one. So, talking about the key highlights of our session, it's in learning advanced imaging technique and optimization in 2D echo. We have engaged in practical application to enhance the patient outcomes and it is going to be very interactive and with case-based discussion. So here is a program structure. We began in the month of June and it's going to be live, interactive and online. We have an experts from echocardiography. So here is a final session. We call it Echo Miscellaneous. So talking about our course director, Dr. Nitin Burkule, we were very honored to get him on board. So talking about him, he's the director, Department of Cardiology at Jupiter Hospital, Thane. He has many affiliations. One of them is Fellow of American College of Cardiology. He has got Lifetime Achievement Award from Indian Academy of Echocardiography, and his publications are he has co-author of ACE Guidelines of ASD and PFO Evaluation, and much more. We have today Dr. Algison as a speaker. He is a professor emeritus from Dr. MGR Medical University, Gwindi, Chennai. He's a retired professor and head department of cardiology, Madras Medical College, and he's got the affiliation of past president of Indian Academy of Echocardiography, past president of Tamil Nadu Cardiology Society of India, and he has got the publications of echocardiography as well. We have Dr. Debika Chatterjee here as well as a speaker. She's a senior consultant and head of Department of Non-Invasive Cardiology, Narayana Health, RDICS, Kolkata. She has got over 25 years of dedicated services, and she has a fellowship in advanced echocardiography. Talking about her affiliation, she's an active member of leading national and international cardiology association, and she's a regular contributor to academic forums as well. And she has also got a multiple publication in reputed nationals and international journals. We have Dr. Shanmuga Sundaram. He is a senior cardiologist in interventional cardiology at Bill Roth Hospital, Chennai. He has got the affiliation of Indian Medical Association and Tamil Nadu Medical Council. He has also presented various research papers in various national and international journals. So we are very happy to get on board our moderator and speakers. Thank you all so much. Talking about the agenda today, we are going to have we are going to hand over the session to Dr. Nitin, followed by all three speakers are going to talk about, beginning from Dr. Algison. He's going to talk about echo in HCM. Then Dr. Debika Chatterjee, she's going to talk on echo in constructive pericarditis and tamponade. And Dr. Shanmuga Sundaram, he's going to talk about echo in infective endocarditis. And then we are going to conclude the session. So by this, I would like to hand over the session to our course director, Dr. Nitin Burkule. Over to you, sir.
Thank you, Raksha.
Yes.
Let us start with the final session.
Yes.
This was a sixth session. There were 6 sessions in this particular eco course, and it was a very good idea of Glenmark Pharma, along with the API, to have this eco course for the MD physicians, and I think that has been a very resounding success. And the today what we are going to discuss is the hypertrophic cardiomyopathy, pericardial disease, and the infective endocarditis. Actually, all these three disease entities, echo has a most pivotal role. As we know that echo has always is the go-to investigation in almost every cardiac disease. It is always the first investigation, and it is the most versatile, low cost investigation, which gives you an immense information. And today that would be reflected in these lectures, on the hypertrophic cardiomyopathy, on the constriction, and obviously on the infective endocarditis. So our first speaker is Dr. Professor Alagation, and he would be speaking on hypertrophic cardiomyopathy. Dr. Alagation, sir, please. Okay.
My slides are visible?
Yes, sir.
Okay. So, understand this is for the MD general physicians who are doing echocardiography. I will go a little slowly so that they will be able to follow the thing. Hypertrophic cardiomyopathy is not a common disease, but it's also not uncommon, especially with the cardiologist. The incidence is about 1 in 500 per person. One case of hypertrophic cardiomyopathy among 500 patients. So if you take the entire population, you can see that hypertrophic cardiomyopathy is not so uncommon. What is cardiomyopathy? Cardiomyopathy is a myocardial disorder in which the heart muscle is structurally and functionally abnormal in the absence of coronary artery disease, hypertension, valvular heart disease, congenital heart disease, sufficient to cause the observed myocardial abnormality. This is the standard definition of myocardial disorder or cardiomyopathy. The other cardiomyopathies due to hypertension, coronary artery disease should be secondary to valvular heart disease, hypertension, and coronary artery should be labeled as so. Hypertrophic cardiomyopathy, the left ventricular wall thickness is 15 or more millimeters in one or more myocardial segments. It can be measured by echocardiography, transthoracic or transesophageal echocardiography, by cardiac magnetic resonance imaging, or by computed tomography. So if the wall thickness in a person is more than 15 millimeters, we have to consider the possibility of hypertrophic cardiomyopathy. In children, if the Z score is more than 2, then you have to think in terms of increased wall thickness due to hypertrophic cardiomyopathy. When there is an index patient, if you have a relative in whom there is unexplained wall thickness of 13 millimeters or more, then those persons also should be investigated for hypertrophic cardiomyopathy. The hypertrophic cardiomyopathy is a genetic disease. It is a sarcomeric gene which is abnormal, which produces the hypertrophic cardiomyopathy. The common gene abnormalities are these two ones. Myosin binding protein C and beta myosin heavy chain 7. So these are the two sarcomeric genes which are commonly abnormal in patients with hypertrophic cardiomyopathy. There are other genes which has been described. Almost there are 100 genes which has been described. So if you take a patient with left ventricular hypertrophy, the sarcomeric gene abnormality producing hypertrophic cardiomyopathy is 40 to 60%. In 25 to 30%, we will not be able to find out any genetic cause. In 5 to 10% of the patient, it is non-sarcomeric and non-sarcomeric causes of left ventricular hypertrophy due to other genetic abnormalities or due to amyloidosis or drug-induced left ventricular hypertrophy. So when a patient with increased thickness of the left ventricle more than 15 millimeters comes to you, then first thing we have to rule out is the secondary causes like aortic stenosis, systemic hypertension, etc. We have to consider and then exclude those causes. After excluding this, if you think it is due to a primary myocardial disorder, the first disease which comes to our mind is the hypertrophic cardiomyopathy. Of course, 5 to 10% of the patients with left ventricular hypertrophy will have non-HCM causes. So these are the list of causes which can produce hypertrophy. So if you see here, genetic causes, there are other genetic causes like storage diseases, neuromuscular and mitochondrial diseases, and other malformations, which can produce a picture similar to that of hypertrophic cardiomyopathy. We have to keep in mind those other diseases, which are it is very rare, but a few of the things you can encounter in your practice. How to diagnose the other non-HCM causes? So in these patients, you should follow what is called a red flag approach. A red flag approach is study the pedigree, if you have a child, whether the father is affected or the grandfather is affected, how the siblings are affected. If you put a genetic tree, then you can identify the genetic, say, the inheritance pattern from which we can get an idea about the disease. Then assess the symptoms. If there are other symptoms like paresthesia, deafness, etc., then we have to think in terms of other causes. Physical examination showing some malformation of the face or some postural hypertension, ocular malformations, etc., then it will give you a clue. The ECG abnormalities also, if there is a pre-excitation syndrome or AV block or a pseudo-infarct pattern, they can point to certain types of hypertrophy. And laboratory diseases and echocardiographic findings can give you some idea about the other causes of left ventricular hypertrophy. So when you get a patient with left ventricular hypertrophy, first exclude secondary causes which are common, like systemic hypertension, aortic stenosis, etc. Then go ahead to exclude other genetic causes of hypertrophy. Then we come to the diagnosis of hypertrophic cardiomyopathy. The hypertrophic cardiomyopathy itself was described in 1956, and in 1960s, it was the left ventricular angiogram which was used to diagnose left ventricular hypertrophy, and also the diagnosis of hypertrophic cardiomyopathy is made. In 1960s and 70s, echocardiogram came into existence. So from the echocardiogram, we are able to measure the thickness of the left ventricular walls, like the interventricular septum, left ventricular posterior wall, etc., from which they described the diagnosis of left ventricular hypertrophic cardiomyopathy. Then came the two-dimensional echocardiography, which clearly showed which are the segments which are hypertrophied. In 2000s, you got the CMR, and 2010, the late gadolinium enhancement, which showed the fibrosis. So this is these are the years in which the investigations which are used for diagnosis and assessment of hypertrophic cardiomyopathy has been introduced. For example, this is one of our earlier cases. You can see a left ventricular angiogram which shows a very narrow mid-ventricular cavity with the left ventricular aneurysm. So this is how we diagnosed in the early days. Then we had the echocardiogram which showed the typical findings in hypertrophic cardiomyopathy. Then the two-dimensional echocardiography came, from which we were able to identify the segments, and the the MRI, which is able to show the left ventricular cavity clearly, and we can identify the segments. In patients in whom the transthoracic echocardiography is suboptimal, we can always use the MRI for accurate assessment of the muscle thickness and the left ventricular ejection fraction. As I told you, this is one of our earliest cases, which published in 1980 in our book on hemodeccardiography. The interventricular septum is thickened. The left ventricular posterior wall thickness is normal. So this, we term it as asymmetric septal hypertrophy. If the ventricular IVS thickness is more than 1.5 centimeters and the IVS to LV posterior wall ratio is more than 1.3, then we call this hypertrophy as an asymmetric septal hypertrophy. If this asymmetric septal hypertrophy is associated with systolic anterior motion of the anterior mitral leaflet, then it is almost diagnostic of hypertrophic obstructive cardiomyopathy. If you look at the aortic valve, you can see a mid-systolic closure with fluttering of the right coronary cusp. The left atrium is dilated. So all these findings indicate that this patient has got hypertrophic obstructive cardiomyopathy with a significant LVOT obstruction and mitral regurgitation producing a left atrial dilatation. So going to the hypertrophic cardiomyopathy itself, so how will you classify hypertrophic cardiomyopathy? The classical say classification is obstructive and non-obstructive. Non-obstructive by itself, it means there is no obstruction in the left ventricular flow. There is no evidence of left ventricular outflow obstruction or a mid-ventricular obstruction. Left ventricular outflow obstruction is the most common type. Mid-ventricular obstruction also we encounter in patients with left ventricular apical hypertrophy. So as I told you, so we have to, from the mode echocardiogram, you can identify the thickness of the myocardium, the interventricular septum, you can see marked systolic anterior motion. When the systolic anterior motion is marked, then the left ventricular outflow obstruction is likely to be severe. Similarly, if you look at the aortic valve echo and see there is a mid-systolic closure with fluttering, again, this finding indicates that the patient has got significant left ventricular obstruction, left outflow obstruction. Here in this patient, you can see the left ventricular IVS is also hypertrophied. The left ventricular posterior wall also is hypertrophied. Now we'll go on to the two-dimensional echocardiogram. You can see here the left ventricular interventricular septum is thickened. You can see the anterior and the posterior septum is thickened. Left ventricular anterior wall is markedly thickened. The lateral wall and the posterior wall are mildly thickened. So whenever you get a patient, you have to do a parasternal long axis view, short axis view at the level of the mitral valve, short axis view at the level of the papillary muscle, and short axis view at the level of the left ventricular apex, and assess the myocardial thickness, which are the segments which are affected by left ventricular hypertrophy. We can also assess the left ventricular hypertrophy from the apical views, the apical four-chamber view, apical two-chamber view, and the apical long axis view. From the two-dimensional echocardiogram also, you can identify the systolic anterior motion of the anterior mitral leaflet. And if you put on the color, you can see there is a turbulence in the left ventricular outflow tract. You can see a abnormal papillary muscle which is getting inserted into the left ventricular apex, lower down in the left ventricle. There is a significant systolic anterior motion with left ventricular outflow obstruction. And you can see there is a mitral regurgitation, mild, and you can see the left ventricular outflow obstruction is severe. The gradient is 71 millimeters of mercury. Any gradient more than 50 millimeters of mercury is a severe one, and it has to be treated. So these are the typical findings in a patient with hypertrophic obstructive cardiomyopathy. We can assess the diastolic function from the left atrial outflow pattern and the septal and lateral annulus tissue Doppler. So this patient has got significant left ventricular hypertrophy and also diastolic dysfunction. We can also assess the systolic function by using the speckle tracking. This is called the strain pattern. Here in this patient, if you look at the left ventricular function as measured by ejection fraction is normal, but the left ventricular function assessed by the strain pattern is abnormal. This is typical of most of the hypertrophied heart. Even though the ejection fraction is normal, there is systolic dysfunction which can be picked up by the strain pattern. This is another patient with left ventricular outflow obstruction due to hypertrophic cardiomyopathy, and you can see the entire video here. This is a marked obstruction of the left ventricular outflow tract. You can see the entire left ventricle is hypertrophied. I'm going level by level. You can see that at the level of the mitral valve, at the level of the papillary muscle, it is hypertrophied. The left ventricle again is markedly hypertrophied. The LA is markedly dilated. The LA dilatation is huge in this patient because the left ventricular outflow obstruction is severe and the mitral regurgitation is also severe. So this patient has got a severe LV outflow obstruction with mitral regurgitation. This is another patient. You can see the hypertrophy is marked in this patient. Again, the anterior interventricular septum, anterior wall are markedly hypertrophied. There is almost obliteration of the cavity near the left ventricular apex. But when you put on the color, there is no left ventricular outflow obstruction or mid-ventricular obstruction. There is a trivial mitral regurgitation, but there is no obstruction. So these are the typical findings in a patient with non-obstructive hypertrophic cardiomyopathy. Usually, when the wall is, the thickness is more than 15 millimeters, we have to consider hypertrophic cardiomyopathy. If the wall thickness is more than 20, usually it is primary and almost say it is due to hypertrophic cardiomyopathy. When the thickness is between 13 to 20, then we have to entertain all the other causes, secondary causes of left ventricular hypertrophy. This is another patient with hypertrophic cardiomyopathy. When with a resting, there is no gradient. You can see there is a mild systolic anterior motion of the anterior mitral leaflet. The hypertrophy itself is not very marked, but rest, there is no significant LV outflow obstruction. In these patients, you can bring out the obstruction by doing a Valsalva maneuver. You can see after doing a Valsalva maneuver, the velocity increases to 3 meters, and with further straining, it goes up to 4 meters. So this is a patient with hypertrophic cardiomyopathy with no obstruction at rest, but the obstruction is revealed by doing a Valsalva maneuver. This is another patient with hypertrophic cardiomyopathy. Again, the left ventricular hypertrophy is not that marked. There is a mild systolic anterior motion of the anterior mitral leaflet. Here, again, you can see there is no significant obstruction in the LVOT, but after a ventricular premature beat, you can see a significant gradient across the left ventricular outflow tract. This again indicates that the patient has got latent left ventricular outflow obstruction. This is the Brockenborough-Blondwall phenomenon, which has been described in the cardiac cath. It is the equivalent in the Doppler. So this again shows the same findings, the gradient increasing after an ectopic beat. Another type of obstruction which occurs in hypertrophic cardiomyopathy is the midventricular obstruction. You can see a significant midventricular obstruction. There is a mosaic pattern in the midventricle, and the Doppler pattern also has got a typical dagger-shaped pattern which occurs in left ventricular outflow obstruction, also occurs in midventricular obstruction. This is another patient with midventricular obstruction in whom there is a apical aneurysm. So there is a significant dilatation of the left ventricular apex with akinetic segment. And because of this akinetic segment pushing the flow into the left ventricle, there is a diastolic flow which is picked up by the Doppler. You can see this flow occurs during diastole. And even you see this pattern in the midventricle, it is almost diagnostic of midventricular outflow obstruction with left ventricular apical aneurysm. And it can be confirmed by MRI. You can clearly make out the left ventricular apical aneurysm. Moran has described different types of morphological types. They are called sigmoidal types, reversed curve type, apical type, and neutral type. So the importance of this is the reverse curve type is the one which is commonly associated with genetic abnormality. We have about 80% of the patients with reverse curve type will have genetic abnormality, and the apical HCM about 30%, and the neutral HCM about 40%. So if you see the hypertrophic cardiomyopathy itself, most of the patients will have the sigmoidal or the reverse curve type of hypertrophy. So this is a patient with reverse curve type. The upper 1/3 of the septum is hypertrophied, but the rest of the left ventricle is normal. The patient has got a significant LVOT obstruction. And this patient has got a reverse curve type. The left ventricle, instead of being concave on the left ventricular side, it has become convex. So indicating that the patient has got a reverse curve type of hypertrophic cardiomyopathy. And this is the apical type of hypertrophic cardiomyopathy, where the left ventricular cavity is markedly narrowed, and in the left ventricle, there is no cavity at all. So this type of apical type, sometimes after a few years, can develop midventricular obstruction and left ventricular apical aneurysm. And this is a neutral type. Again, this patient has got a left ventricular outflow obstruction, severe. So these types are useful only for identifying the type which is associated with genetic abnormalities. Some types are commonly associated with the genetic abnormalities, and if you want, you can do genetic studies. Uncommonly, there can be some cases where the hypertrophy occurs in few segments only. Here you can see the inferior septum and the inferior wall alone are hypertrophied. All the other segments are normal in thickness. This is another patient where the anterior septum and the anterior wall alone are markedly hypertrophied. So the hypertrophic cardiomyopathy pattern can vary depending upon the expression of the gene. It can affect the entire left ventricle, interventricular septum, and the anterior wall. It can affect the inferior wall. It can affect the lateral wall. So these types, we have to go through the echo completely and diagnose the hypertrophic cardiomyopathy. This is the typical Japanese type of cardiomyopathy with a spade-shaped left ventricular cavity where the apex is markedly obliterated. This is the cardiomyopathy in which there is the ECG shows left ventricular hypertrophy with deep T-wave inversion. These are the cases which has been described by Yamaguchi, or the Japanese type of hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy in later stages can develop cardiac failure. There are two types of cardiac failure: heart failure with preserved ejection fraction. This is a patient with marked hypertrophy of the interventricular septum, the anterior wall, the lateral wall, and the posterior wall. So after some time, they can develop hypertrophic cardiomyopathy with cardiac failure. So this patient also had a significant left ventricular outflow obstruction. And if you look at the LAVOT Doppler and the tissue Doppler and the pulmonary vein, you can see that this patient has got typical type 3 diastolic dysfunction or the restrictive pattern, and this patient was in cardiac failure with preserved ejection fraction. In some of the patients with hypertrophic cardiomyopathy non-obstructive type, in the later ages like 50 or 60, they can develop global hypokinesia and left ventricular dysfunction. So this is another patient with genetic type of hypertrophic non-obstructive cardiomyopathy who developed left ventricular failure due to left ventricular dysfunction. These patients with left ventricular dysfunction are also prone for sudden cardiac death. That is one of the indications for putting a cardiac pacemaker, ICD. There can be other abnormalities like long cardiac. This is a patient with long cardiac in a patient with hypertrophic cardiomyopathy. This is a patient with hypertrophic cardiomyopathy with infective endocarditis of the anterior mitral leaflet. There is a vegetation about 10 millimeters in size. This is because the anterior mitral leaflet hits against the interventricular septum and the endothelium is eroded and becomes a nidus for infection. So sometimes, rarely you can get infective endocarditis. This is another patient with rheumatic mitral valve disease with hypertrophic cardiomyopathy. This patient has got a mitral stenosis, mitral regurgitation, and also there is a significant left ventricular outflow obstruction. And we have seen this is a patient from Madras Medical College. You can see marked hypertrophy of the interventricular septum. The left other portions of the ventricle also mildly hypertrophied. And this patient has got a left atrial myxoma. So hypertrophic cardiomyopathy patients, 80% of the patients, they do well. They live long and they can develop other diseases also. Like this patient has developed left atrial myxoma. We have seen patients with aortic valvular stenosis, which is common in older people. They can develop diabetes, coronary artery disease, and other pathologies which are encountered in the elderly. The abnormalities of the papillary muscles are common. The common one is the displaced papillary muscle, which gets inserted into the lateral wall, lower portion of the lateral wall, and the left ventricular apex. And this is the one which produces mid-ventricular obstruction. This is another abnormality. There can be deep crypts inside in the left ventricular wall, and these are all congenital, genetic defects which has been described in hypertrophic cardiomyopathy. You can clearly see the flow into the crypts, and this patient had a mid-ventricular obstruction, and you can identify the crypts in the MRI also. This is the MRI which shows the crypts in the left ventricular muscles. There is another patient with marked hypertrophy of the interventricular septum, left ventricle. The entire left ventricle is markedly hypertrophied. The thickness was more than 38 millimeters in this patient. And you can see again the marked hypertrophy in the 4-chamber view, 2-chamber view, and the long axis view. And this patient had a significant LV outflow obstruction, a gradient of almost 100 millimeters, and mitral regurgitation. The same patient had a right ventricular outflow obstruction also, a gradient of 36 millimeters across the right ventricular outflow. Right ventricular affection is occurs in about 20 to 30% of the patients. The right ventricle is hypertrophied, but right ventricular outflow obstruction itself is very rare in hypertrophic cardiomyopathy. The other causes of hypertrophy which you have to exclude is hypertensive heart disease. So the hypertrophy is usually moderate. It is not marked. If it is thickness is more than 20 millimeters, you can straight away think in terms of hypertrophic cardiomyopathy. But if it is 13 to 15 or 16 millimeters, we have to consider the possibility of hypertensive heart disease. The other cause is the amyloidosis. When you have bright echoes with the dilated left atrium, with no alveolar obstruction, significant mitral regurgitation, thickening of the mitral valve, interatrial septal thickening, etc., are the findings in patients with amyloidosis. In this patient, there is a mild mitral regurgitation. The entire left ventricle is hypertrophied again. And you can look at the interatrial septum is also significantly thickened in this patient. So, of course, we have to do other tests to clinch the diagnosis of left amyloidosis. And any patient with hypertrophic cardiomyopathy, we have to go through the risk of sudden death. You have to assess the risk of sudden death by looking at the left ventricular wall thickness, ventricular tachycardia, non-sustained ventricular tachycardia in the Holter, unexplained syncope or family history of sudden cardiac death. These are the four parameters which are more important for assessing the risk of sudden death. And there is a Euro score. European Society of Cardiology has come out with a risk score. And if it is risk score is less than 4%, then it is mild. The risk is low. If the risk score is more than 6, then the risk is high, and these patients ICD is indicated. In 4 to 6, we can look at other parameters like left ventricular fibrosis of more than 15 millimeters as shown by the gadolinium enhancement, left ventricular apical aneurysm, or left ventricular systolic dysfunction. If these three parameters are present, then they are at risk of developing ventricular tachycardia and sudden cardiac death. And the ICD is usually indicated. So the most important thing when you want to treat any patients with medicine or to submit them for other types of treatment, the most important thing is diagnosis, 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 as told by William Osler in his book, Principles and Practice of Medicine. Thank you.
Uh, Thank you, Professor Alagason. This was an exhaustive summary of the echo in hypertrophic cardiomyopathy, and I think all the points were perfectly covered. So we have got we have got certain questions in our chat box. The first question from our delegate is for borderline hypertrophy that is between 13 to 14 millimeter, what is your next step?
The usual thing is when the patient, the muscle thickness is 13 to 14, the thing is if the patient has got left ventricular outflow obstruction or mid LV obstruction with a mild to moderate, mild hypertrophy, then diagnosis is obvious. When there is only the thickness without any obstruction, and if the patient doesn't have a history of hypertension, etc., then we have to say label it as probable hypertrophic cardiomyopathy and then follow up these patients. Usually, hypertrophic cardiomyopathy, non-obstructive with a 13 to 14 millimeters thickness, usually behaves benignly. And the other thing is the left ventricular hypertrophy occurs usually around puberty. Most of the patients, even though the genetic defect is present, it is very uncommon for the hypertrophic cardiomyopathy to appear in children. If it occurs in a child, the prognosis is not at all good. If you have a 10-year-old or 15-year-old with hypertrophic cardiomyopathy features, the prognosis is not good. Whereas usually the hypertrophy occurs during puberty, and sometimes it occurs during the 40s, 50s. We have seen normal echo before 40 years of age, developing hypertrophic cardiomyopathy in later age group. So the lesser the thickness, the later the age at which it appears, the absence of a left ventricular outflow obstruction, mid-LV obstruction are good prognostic signs. So these patients 13 to 14, you can follow up. Most of them will develop little more hypertrophy after 5 years or 10 years like that, in which case you can definitely diagnose it. The other thing you can do is genetic studies. If the gene is positive, then it almost clinches the diagnosis in those patients.
Yes, correct. So suppose someone in the family is having an hypertrophic cardiomyopathy, and so that the proband and the first degree relatives of that proband, if you find an thickness of 13, 14 millimeter, that definitely you will take it
You take it,
seriously. That
yes.
this particular individual in the family is probably developing hypertrophic cardiomyopathy, because then we'll not wait for 15 millimeter to diagnose it. So that is the perfect one. Secondly, there is a question is that the question is framed this way. Okay, suppose the hypertrophic cardiomyopathy patient who has a preserved EF, are there any echo parameters which will predict the progression? That means probably the outcome. So, I mean, what are the bad prognostic features on the echo in the hypertrophic cardiomyopathy?
Actually, a patient with preserved EF, heart failure with preserved EF is little more difficult to treat than the one with heart failure with reduced ejection fraction. If the patient has got heart failure with reduced ejection fraction, then all the drugs which are used, guideline directed medical management, can be used for the treatment. Whereas with the preserved EF, the treatment options are limited. So it is mostly limited to symptom relief, and the progression is usually we can't halt the progression of the disease. And usually the heart failure with preserved ejection fraction, if you do a MRI, etc., there will be significant left ventricular fibrosis, gadolinium enhancement, or even in between the muscles there can be fibrosis, which can happen and produce uh, heart failure with preserved ejection fraction.
Yeah.
So one
I
of the
think the
things which we
question, I think the question is more oriented on the echo. What are the high risk prognostic features that they, I think, want us to enumerate?
the diagnosis is similar to that. You have to be sure about the diastolic dysfunction first, and then if there is a left atrial dilatation, pulmonary hypertension, etc., then it almost clinches the diagnosis of heart failure with preserved ejection fraction.
Yeah. Then there is this question is about the dynamic LVOT obstruction. Now, as we know that it is very, very labile, sometimes you may have very minimal gradient, sometimes you may have significant gradient in various different physiological situations. So the question comes is that should we be doing Valsalva maneuver in all the patients of hypertrophic cardiomyopathy? And if yes, how do we actually do the Valsalva on the patient while doing the echocardiography? I think that will be a very good teaching point or giving the tips for the people who have started doing echoes in the HCM.
Uh, in any patient with mild systolic anterior motion, there is no, let's say, there is no LVOT gradient, we have to do a Valsalva maneuver. So doing a Valsalva maneuver, teaching a Valsalva maneuver is a most difficult thing. We have to ask the patient to take a deep inspiration, then completely breathe out, and without taking the breath, he has to strain as if he is going to passing a motion. So he should not take the breath after exhalation. So that is we have to teach them properly and then try to do the Valsalva maneuver. The other thing is some of them ask the patient to blow the cuff and all that. I don't know. I have not used it. I am not very familiar with that type of Valsalva maneuver.
Yes. And the next question is once we are diagnosed on hypertrophic cardiomyopathy in the proband, how do you go about the family screening, and how frequently should we be doing family screening?
The family screening, say actually, if there is a sibling who has got hypertrophic cardiomyopathy, all the other siblings should be evaluated at the time when the diagnosis is made. And as I told you, the hypertrophy occurs mainly during the puberty or at that time. So if you have a person who is about 20 to 25 years old, then if the person is negative, most of the probably he has escaped the abnormality. Otherwise, you can do a genetic study in all the people. But finding out a gene in the sibling also is not going to be definitely indicate that he is going to develop the problem, because say if there is one person who has got hypertrophic cardiomyopathy, genetic gene is positive, If his brother is gene positive, not necessarily he should develop the hypertrophic cardiomyopathy disease. So in those patients, we have to check for hypertrophy at different intervals, maybe at 5-yearly intervals, and find out whether he is developing the disease. Because there are other genes which can modify the expression of the hypertrophic cardiomyopathy gene itself.
Exactly. So that is how the I think the echo screening or echo and ECG screening I think works out to be much cheaper also than doing the genetic testing or the cascade testing in the family in our Indian scenario. So I think all those before the puberty we should screen those siblings every yearly, and thereafter I think at least 4 to 5 yearly. And generally I think it is okay till 40, 50 years of age. Thereafter I think it really doesn't matter much.
Doesn't matter.
Doesn't matter. And then I think that doing ECG and echo in our Indian setting is much cheaper. And that way, if you are doing it every 4 or 5 yearly, I think it is not a very big burden for the family. And as we know, the genetic testings are still much more expensive. So I think we will conclude here. I think we have touched all the aspects of hypertrophic cardiomyopathy, especially from the echo imaging point of view. So we will be now shifting our gears and going to the another most important part of the heart, and that is pericardium. And as we know, the pericardium in the form of either constriction or in presence of an effusion causing a tamponade is a very important entity with a very severe morbidity and mortality. And it has got a very unique pathophysiology, and that only echo can show you non-invasively. So it's a very immersive experience to do a pericardial echo for a constrictive pericarditis. And for that, Dr. Debika Chatterjee will be giving us a talk for both the pericardial constriction also and for the tamponade also. Dr. Devika.
Thank you, Dr. Nitin. I am sharing my screen. Yeah, this one. Can you see my screen?
Yes, we can see it. Yeah.
Yeah. So, good evening, everybody. I'm going to speak on pericardial tamponade, and that will be followed by constrictive pericarditis. So, just a second.
At the bottom, you can see before minus sign, there's a slideshow option.
Where?
At the very bottom, right bottom.
Right border.
Just
Top.
before minus sign, there's one cup symbol.
Yeah, that is not, I'm not getting, I don't know.
Just
why.
a second, can you approve? I'll just make it.
Approve, okay. Confirm.
Can you click on that slideshow option at the left? You can see at very top.
Top sharing. Share.
See, you have this slideshow option, that insert, draw, design, transition, animation slideshow. So they just click on the slideshow.
Yeah, that I'm not getting. I don't. Oh, yeah, I got it now. Yeah.
Yeah,
Yes.
correct.
Okay, ma'am.
So, pericardium is a sac. It has got two layers, as you know, a visceral layer, which is the inside layer just next to the myocardium, and the outside layer is the parietal layer, and in between there is a sac which contains normally around 15 to 50 cc of the fluid. So when we do echocardiography of a normal patient, normal person with a normal healthy pericardium, it is really difficult to say differentiate the pericardium. We can see the epicardial pad of fat, and this bright, dense layer inseparable from the epicardial fat is the pericardium, we hardly look at it. See, this is the normal pericardium, having a little very chink of pericardial effusion on the posterior aspect near the groove, which is a normal finding. So now when this amount of the fluid increases, we say pericardial effusion, the etiology of which may be different, like inflammation, trauma, non-infectious causes like congestive heart failure, hypothyroidism. It may happen post-CABG or in a case of malignancy. So it is the echocardiography, which is a primary investigation modality to identify this pericardial effusion. It can pick up very easily the pericardial effusion, the echolucent space adjacent to the cardiac structure, and it has got it has got a tendency initially to get into the posterior aspect of the heart, where you can assess it in the parasternal long axis, just distal to the this group. So this clear space outside the myocardium is the pericardial effusion, which is readily visualized in Plaque's view and also in other views. And while talking about the pericardial effusion, it is essential for in each one of us to differentiate it from pleural effusion, because we get the patients where the patients are having both pleural effusion, a huge pleural effusion, and maybe a small pericardial effusion, and we should not make mistake to comment the pleural effusion as pericardial effusion. So it is necessary to differentiate these two. So how do we do that? We go to the parasternal long axis view. Look here, this is the descending thoracic aorta, a landmark of parasternal long axis view. So the effusion which is anterior to it is the pericardial effusion, and posterior to the descending thoracic aorta is the pleural effusion. So it is very, very essential to differentiate it. Now, I will talk first to the echocardiography of pericardial tamponade or a cardiac tamponade, which is a life-threatening condition, a medical emergency, and must be treated promptly because patient is having hypotension, dyspnea or orthopnea, having tachycardia, cold coming extremities. So you have to move very fast to diagnose it and at the same time to treat it. So what it is, tamponade is actually, it is a complication of pericardial effusion. There is fluid in the pericardium which impairs the diastolic feeling of the ventricle to such an extent that there is hemodynamic compromise, which leads to the decrease in cardiac output. So, though it can be diagnosed by chest X-ray, ECG, CT, CMR, etc., but echo is the primary investigation, and echo can identify the signs before the clinical manifestation of tamponade. So, it helps in diagnosis as well as it helps in treating the patient by guiding and monitoring the pericardiocentesis, because the risk of death in tamponade depends upon the speed of diagnosis. It reduces if you move fast to diagnose and treat the patient. So if we look at the tamponade physiology, normally pericardial pressure is subatmospheric, that is negative throughout the cardiac cycle. Now, as there is increasing intrapericardial pressure because of the pericardial effusion, this pressure becomes positive from negative. So as a result of which, you see the intracavitary pressure becomes less than the intrapericardial pressure, so the cavity collapses. As the cavity collapses, its diastolic feeling is impaired, leading to the hypotension. So this is the basic physiology. Now, how much fluid is needed to cause tamponade? Well, it is not only the volume of the fluid which is important. It is also the rate of accumulation which is important to know how the volume and the rate of accumulation can cause the tamponade. Here you see, this is the pressure volume curve in tamponade. If you compare two patients, in this particular patient, a rapid accumulation of only 150 cc of pericardial fluid has given rise to the signs of tamponade, though it hasn't crossed the limit of pericardial stretch. On the other hand, this patient, where there is accumulation of 1000 ml of pericardial fluid, it is tolerated very well. You see, the patient hasn't developed any signs of tamponade till this point, and once it crosses the limit of pericardial stretch, the pressure increases and patient goes into tamponade. So we have to remember that even if small amount of blood is accumulated in the pericardium very fast, like following the removal of the temporary pacing, where in the cath lab it happens, even 100 cc of the blood causes the tamponade. Now, which chamber is affected first? Obviously, it is the low pressure chamber, which are atria, are affected before the high pressure chamber, which is the ventricle. Then, which phase of cardiac cycle there is a collapse of the chamber? So, it is during that phase where the pressure of that particular chamber is lowest. Like in ventricle, the early diastolic phase shows the lowest pressure in the ventricle, and in the atrium, it is during the ventricular systole when the pressure of the atrium is lowest. So let us see what are the signs we get in tamponade. So it is the systolic RA collapse, which is the earliest sign. It has got a high sensitivity. It begins in late diastole and continues into systole for a variable period. Well, we must look at the length of the time of the collapse. This is the four-chamber view. You can see the RA is collapsing. This sign is best visualized in apical four-chamber, a bit modified. Look at the RA collapse, how it is collapsing, and it is lasting almost throughout the systole. And if it lasts for more than 1/3 of the cardiac cycle, the specificity increases to 100% and the sensitivity increases to 94%. So you have to remember that it is the duration of the inversion of RA free wall which is important, because a brief inversion of the RA free wall can occur without tamponade, because it is a very, very flexible wall. RA wall is very flexible. So it has to last for some time in the systole. Now next, the diastolic collapse of RV. You see, you can pick it up in the parasternal long axis as well as in apical four-chamber. Here is the RV free wall. This is a sign which has got a very high specificity. It precedes the onset of clinical tamponade. So once you get it, you have to move very, very fast. It occurs in early diastole. It may be transient or may persist for some time, but if it is present, it has got a high specificity of say almost 100%. And when RV diastolic collapse is seen, cardiac output is at least reduced by 20%. Here you see the RV is collapsing during the diastole. Patient usually has the tachycardia during this phase. So once you get during the tamponade, I mean, so once you get this, you have to move very fast for pericardiocentesis. You can assess this collapse by using the M mode. You see in the ECG, you can see the diastolic collapse is taking place. This is the phase of systole. This is diastole. So you see it's collapsing RV wall. And next, a very, very important sign which can be easily picked up from subcostal view is the dilated IVC with minimal respiratory variation. It has got a very, very high sensitivity of 97%. You see, you ask the patient to sniff, and if it is possible, it doesn't show any respiratory variation. Normally, IVC reduces its is reduced in its size by more than 50% during inspiration, and that disappears, and IVC is dilated. So see, in the last patient, I have shown you a large effusion with tamponade, but look at this patient. Though there is a large effusion, look here, the RA is not collapsing, RV is not collapsing. Look at the parasternal long axis, there is no collapse, though there is a large effusion. And look at the IVC, size is normal and it's collapsing more than 50% during the inspiration. So you have to look for the RA collapse, and very, very importantly, RV diastolic collapse, and also the IVC sign for finding the tamponade. And mitral flow variation with respiration is more than 25%. And in case of tricuspid valve, it is more than 40% variation. And this variation I am going to describe while talking about the constrictive pericarditis. It happens in cardiac tamponade also. And you may get, if the effusion is very large, a sign called swinging heart. As you can see, the heart is as the heart is oscillating inside the pericardial sac, like a pendulum. It's a very good sign of tamponade, and this patient needs the pericardiocentesis immediately. So, and subcostal view is very, very important in tamponade, because this is the view where you can demonstrate the fluid in front of the RV, so that if you plan to do the pericardiocentesis from the subcostal approach, you will never puncture the RV free wall, because there is enough fluid, and the needle can puncture the pericardium, and you can easily put the pigtail and take out the pericardial fluid from this pericardial sac. So you must remember that following the CABG, often we see this type of picture. This is the hematoma, a large hematoma. These also may cause the tamponade. So this type of finding needs, you need to move the patient to the OT for removal of such a big clot. Because the patient is bleeding basically inside the pericardium. So this clot needs to be removed to avoid the tamponade. Now let us move to the constrictive pericarditis from the tamponade. Here, the pericardium has become very thick and rigid, obviously due to the previous purulent pericarditis or tubercular pericarditis, as you know. So what happens? It is the thick, rigid pericardium which has limited the diastolic filling of the heart, of the ventricles. It leads to two fundamental abnormalities. One is anatomic, another is physiologic, leading to the filling dysfunction. So now let us look at the anatomic findings of constrictive pericarditis. So what is the anatomic finding? It is the abnormal pericardium. What type of pericardium we get? We get a very thick, you see the pericardium has become very thick. Normally we can't even see. It has become adherent, calcified at some of the places, and sometimes you may see the caseous material. You see this ecodense material which is attached along the visceral pericardium is the caseous material, and there is some effusion. So we call it effusive constrictive pericarditis. And a very, very important finding is the dilated fixed IVC and the engorged hepatic vein in constrictive pericarditis because of the systemic venous congestion. This is the hepatic vein which is joining the joining the IVC, and we measure it. We find it 23 millimeter, which is dilated. And with sniffing, it is not responding to the size is remaining same almost, you see. So it's a dilated and fixed IVC, which sometimes may be the first sign you pick up for constrictive pericarditis. So subcostal view is very, very important to pick up the findings of pericardial pathology. Now, after the anatomic findings, let us move to the physiologic findings. As I said, it's the feeling dysfunction with hemodynamic findings. So what it is? It is because of the exaggerated ventricular interdependence. What is ventricular interdependence? Let us see what it is normally. It is basically a normal phasic change in ventricular feeling in relation to respiration. So what happens in a normal heart? During inspiration, intrathoracic pressure decreases. That leads to increased venous return to the right side of the heart, and that leads to increase in the RV diastolic feeling without impairing the LV feeling. So what happens normally, though there is a change of the feeling, increase in the RV feeling, but no impairment in LV feeling, and that does not give rise to any significant change in the mitral valve and tricuspid valve inflow velocity. It is less than 10% and hardly it makes any difference. But these particular interdependence becomes exaggerated in constrictive pericarditis because this thick pericardium, rigid pericardium, has resulted in a fixed total end-diastolic volume. So during inspiration, when the right-sided feeling is more, the septum bulges towards the left, and during expiration, as the mitral flow increases, the septum moves towards the right. So this exaggerated phasic change results in more than 40% respiratory variation in the tricuspid valve flow velocity and more than 25% in mitral valve, along with the expiratory diastolic flow reversal in hepatic vein. I'm going to show you. And these particular exaggerated ventricular interdependence give us host of hemodynamic findings in constrictive pericarditis, giving us 2D findings, M-mode findings, and Doppler findings. Let us see one by one. In two-dimensional echo, what we see? We see the septal bounce. You see, it's a shuddering motion of the septum because the thick calcified cement pericardium has resulted in fixed in diastolic volume. So as the diastole goes, a time comes when it has reached its maximum limit. The cemented pericardium doesn't allow it to receive further, and the septum in the middle shudders. So this is the sign which we get, as you can see here, the short axis and also in the fourth chamber. And also we can appreciate it by doing M-mode. You see, this is the respirometer curve. Inspiration is this peak, and this is the expiration. So during inspiration, the septum suddenly moves towards the left, and then goes suddenly towards the right. So, and when we look at the Doppler finding, the mitral valve flow, see, the variation of inspiration to expiration is more than 25%. So in this particular case, it was 41%. So this phase is inspiration. See, it has come down, and in the expiration, it has gone up. So the variation is more than 25% across the mitral valve, and across the tricuspid valve. When we checked, the variation was 41%. So it is more than 40%. So these are the signs which are favoring the constrictive pericarditis. Now let us look at the hepatic venous flow. Hepatic venous flow, what is happening during expiration as the septum is moving towards the RV? This RV cannot accommodate more blood because it is cemented. So that extra blood goes back to the hepatic vein and we get the expiratory flow reversal. This is the phase of expiration. So that is the flow of the flow reversal in expiration in the hepatic vein. And now let us look at the TDI velocity of the mitral annulus. So this is the septal annulus and this is the lateral annulus. In the septal annulus, look at the velocity, it's 12 centimeter per second. The E wave velocity also was preserved and E prime also is high. So E wave is more, E prime is more. So that results in low E by E prime in case of constrictive pericarditis. This is very, very important to know because this is one of the findings by which we will differentiate between constrictive pericarditis and restrictive cardiomyopathy. So E wave is high, E prime also is high, E by E prime is low. Now, another finding we get in constrictive pericarditis, which is called annulus reversus by tissue Doppler imaging. So, when we do in a normal subject, the septal annular velocity is less than the lateral annular velocity. If this is 10, lateral annular velocity is 12. So, almost the lateral annular velocity is more by 25%. But in case of constrictive pericarditis, the septal annular velocity is more than the lateral annular velocity because you look at the lateral annulus, it is tethered to the adjacent fibrotic and scarred calcified pericardium. So what is happening? See, left septal E prime 12 centimeter per second and lateral E prime 11 centimeter per second. Normally, if this is 12, usually in the lateral annulus, we get 14 or 16 centimeter per second. But in this particular case, the lateral annular velocity is less than the septal annular velocity. So what is happening? This is called the annulus reversus because the septal annular velocity is more than the lateral annular velocity. So it is a reverse of the normal phenomenon. Speckle tracking echocardiography is normal in constrictive pericarditis with preserved GLS, as you can see in this case, minus 18.6%. Now, when I talk about the constrictive pericarditis, it is essential to say something about the difference between constrictive pericarditis and restrictive cardiomyopathy, because they have similar clinical presentation, similar physical examination signs, and most importantly, too much of overlapping of echocardiographic and hemodynamic features. So distinction remains a challenge and it has to be done because constrictive pericarditis is a very much treatable condition by surgery, and RCM is, of course, it is with medicine we can give, but it is always not always very good. But constrictive pericarditis patients, they come back to almost normal levels. So it's very, very essential to differentiate it. So if we look, constrictive pericarditis is the thick, rigid pericardium which is limiting the diastolic filling. But in restrictive cardiomyopathy, it is the myocardium, rigid ventricular myocardial wall, which limits the diastolic filling. But in both the conditions, you get these two fundamental abnormalities. One is the anatomic and another is physiologic. And of course, in restrictive cardiomyopathy, though in constrictive and restrictive, see, you will get similar type of IVC, which is plethoric and engorged hepatic vein, and there is no respiratory variation. You don't know which one is CP and which one is RCM. So now, as we go to the precordial views, you see anatomically, you will see this is a case of cardiac amyloidosis. The pericardium, the myocardium is thick, and this is a case of sarcoidosis. You see scarred, thinned myocardium. And very, very importantly, we always see the biatrial enlargement. This is another variety of restrictive cardiomyopathy. But look at the pericardium. It's absolutely healthy. There is no thickening, no calcification, no cementing of the pericardium, you see. So normal pericardium, but it is the myocardium which is diseased, which differentiates from the constrictive pericarditis. And if you look at the mitral and the tricuspid flow, there is normal respiratory variation. There is no exaggerated the ventricular interdependence, resulting in respiratory variation of mitral and tricuspid, and so it is normal in case of restrictive cardiomyopathy. Now, how would be the mitral inflow? As I said, the E wave in constrictive pericarditis is high, so also in restrictive cardiomyopathy, E wave is very tall and a small A wave. So now how to differentiate? It is the tissue Doppler which will differentiate, which will help us to differentiate constrictive pericarditis from RCM. So now let us look how it goes. So in case of restrictive cardiomyopathy, if you do the diastolic flow velocity, you know tall E and small a. But if you do the tissue Doppler velocity of septal annulus as well as the lateral annulus, everywhere you will see very low E prime, A prime, S prime in both the septal annulus and the lateral annulus. See, everything is less than 5. So it is very, very important finding to differentiate from the constrictive pericarditis. In constrictive pericarditis, we saw well-preserved E prime velocity in the septal annulus. So what will happen to the E by E prime? Here in normal Doppler, conventional Doppler, we got a very tall E, small a in restrictive cardiomyopathy, but E prime is very small. So you will get a very high E by E prime. On the other hand, in constrictive pericarditis, I have already shown you E wave is tall, E prime is tall, so very low E by E prime, less than 8 or 10 is the ratio. So this is one. And then hepatic venous flow, you will see enhanced diastolic flow during the inspiration instead of expiration in case of constrictive pericarditis, because it is the non-compliant RV which cannot accommodate the increased return, and that results in the inspiratory flow reversal. And also we use the speckle tracking. In case of restrictive cardiomyopathy, the GLS will be very, very low. And if you get a case of cardiac amyloidosis, you will get the typical cherry at the top pattern with low GLS. And of course, in the modern era, it is the multi-modality imaging which confirms our diagnosis of constrictive pericarditis and restrictive cardiomyopathy from the CT and the MRI with contrast. Thank you.
Uh, Thank you, Dr. Devika, for that exhaustive review of tamponade and constriction. We have certain questions with our in our chat box, and the first question obviously is related to the most important. I mean, the most you can enumerate the most important practical features to differentiate restriction and constriction, which you
Yes.
have already covered. Yeah.
Yeah, first of all, as I said, IVC is you cannot differentiate. It's dilated and fixed in both the conditions. So immediately we go to the epicardial views to look at the, say, suppose four-chamber view. We will see biatrial enlargement in case of restrictive cardiomyopathy, along with some features of restrictive cardiomyopathy like cardiac amyloidosis or sarcoidosis. On the other hand, in constrictive pericarditis, bilateral enlargement is plus minus. You may not get if the patient is having AF or some other thing, you will get. Otherwise, a normal myocardium, but the pericardium will be thick, calcified, and you may get some caseous material in the pericardial cavity with some effusion. So look at the pericardium as well as the myocardium, and bilateral enlargement is very, very important.
Okay. The next question is about the mitral annular Doppler difference between the CP and the restrictive cardiomyopathy.
Yes. See, as I said, in constrictive pericarditis, see, in the mitral annulus, septal annulus, and the lateral annulus. So in constrictive pericarditis, septal annular is absolutely fine. It is not involved. So E prime velocity will be normal. On the other hand, the lateral annular velocity, E prime, will be less. I mean less, relatively less, because lateral annulus is cemented with the thick pericardium. On the other hand, in restrictive cardiomyopathy, both the annuli will show very low E prime, A prime, and S prime. All the tissue Doppler velocities will be less in restrictive cardiomyopathy.
Exactly. So a very low values of E prime, A prime,
E
S
prime
prime
and S
virtually
prime
rules out the constriction. That is the
constriction.
way we can put it. There is one more question is that in tamponade, which chamber collapses first, whether the RA or the RVOT?
RA is the earliest sign, but usually we move forward with the RV collapse. I mean, it's a very, very specific sign.
Correct.
RA is the earliest sign.
Correct. And it's more of a systolic one
True.
for dilated
Yes,
feedback.
yes, yes.
Yeah. Thank you, Dr. Devika, for that detailed description of the constriction and the restriction and also the tamponade physiology by echo. We will move on to the last lecture. This lecture is about the infective endocarditis, and I'll call upon Dr. Shanmuga Sundaram to deliver this lecture.
Good evening, dear friends. The advantage of echocardiography in dealing with any illness is it tells you about the altered structure, tells you about the altered physiology. It identifies the etiology, tells you about the severity of the problem. It also tells you about the prognosis, guides you to manage the patient, and it also helps you to follow up the patient with the disease. Infective endocarditis is not an exception. Echocardiography does everything in infective endocarditis. He doesn't like it, but it is my duty to thank Dr. Aragesan, my teacher turned friend, for sharing some of his collections for today's presentation. Infective endocarditis is a rare disease. 3 out of 100,000 persons in the population, but it is a serious disease with poor prognosis, high mortality, long hospital stays, and frequent need for surgical intervention. We should realize that there is a change in epidemiology. What was a subacute disease predominantly caused by Streptococcus viridans with underlying valvular heart disease and congenital heart disease is now turning to predominantly an acute illness caused usually by staphylococci and fungi, more so in the presence of prosthetic material, electronic devices, central lines, and also caused by IV drug abuse. Classified into left-sided infective endocarditis and right-sided IE. Left-sided endocarditis can be classified as native valve endocarditis and prosthetic valve endocarditis. Prosthetic valve endocarditis can be subtyped into early and late. And device-related endocarditis is a separate class. And whenever there is fever of unknown cause, whenever there is a sepsis with undetermined focus, whenever there is an embolic episode, consider infective endocarditis and use echocardiography to, establish the diagnosis. This is Duke's criteria with which you're all very familiar. Originally proposed 1994, then, modified in 2000. And it tells you the pivotal role of imaging, particularly the echocardiogram, because it is one of the major criteria. The diagnosis is by demonstrating the infection of the myocardial structure or the valvular structure in the form of a vegetation or in the form of some complications like abscess, fistulas, etc. In 2023, the International Society of Cardiovascular Infectious Diseases has recommended some more modifications wherein the usefulness of the cardiac CT as well as PET CT in establishing the diagnosis of IE is added. And apart from the recovery of organisms by routine culture, the usefulness of PCR in identifying the organisms is also included in this revised recommendations. If you look at the value of imaging, either by echo or cardiac CT, it is predominantly by showing the presence of a vegetation or the complication of an infection in the valve or any other structure in the form of an aneurysm, perforation, abscess, pseudoaneurysm, intracardiac fistulas communication, etc. Remember that appearance of any new valvular regurgitation in echo is a useful echocardiographic sign of infective endocarditis. And also remember that worsening or changing of pre-existing regurgitation is not sufficient to diagnose IE. In contrast to what we originally believed. Similarly, appearance of new murmur, is no longer considered as a very valid sign of infective endocarditis. Imaging also can identify dehiscence of the prosthetic valve, and PET CT can identify metabolic activity in either native valve or prosthetic valve, thereby increasing the suspicion of infective endocarditis. How does echo help in diagnosing IE? By identifying the valve infection in the form of vegetation. In the initial stages, it may appear as diffuse valve thickening. In identifying destruction of the valve in the form of occurrence of regurgitation, presence of abscess, perforation of the valve, and extension of the infection to the adjoining structures, the root abscess, fistula, paravalvular leak in prosthetic valves, and pseudoaneurysm, which can involve any structure, but commonly the aortomitral curtain, which can extend, which can rupture into the pericardium or into the intracardiac structures. This is how we should move on. Anyone who is referred for infective endocarditis, transthoracic echo is the first investigation to be done. The sensitivity is less, but it can pick up infective endocarditis or the vegetations quite easily without much of a delay, without much of a preparation. Only when the first transthoracic echo is negative, or if you feel that the image quality is too bad, or if there is vegetation, but if you suspect complications, you should ask for TE. But remember, TE is such a useful investigation in infective endocarditis. It is most often 60 to 70% of the patients with IE, at least one TE study would be required. If TTE, thoracic echo is negative, go for TE. If it is positive, treat it as infective endocarditis. If it is negative, don't stop with that, particularly when your clinical suspicion is quite strong. Wait for a week and repeat the study, either transthoracic or transesophageal echo. It can pick up additional cases of infective endocarditis. And look at the sensitivity and the specificity of transthoracic echo. Sensitivity is less, but transesophageal echo has sensitivity rate of close to 100%. It is particularly so in prosthetic valve endocarditis. Transthoracic echo alone may be enough for right-sided infective endocarditis because TE is not going to tell more information about right-sided infective endocarditis. Similarly, in a patient with aortic prosthesis, if there are any aortic root lesions in the anterior part of the aorta, it is the transthoracic echo which offers much better information than transesophageal echo. The formation of vegetation is well known to you. There is a hemodynamic trauma to the endocardium. Bacteria get adhered. The inflammatory cells accumulate, fibrin accumulate, and result in the formation of a vegetation. Location of the vegetation can tell you that it is likely to be caused by infection. In valvular diseases, for example, in MR, the atrial side is the preferential site. In aortic regurgitation, it is the ventricular side of the AV semilunar valve is the favorite site for the vegetations to form. And because the regurgitant jet, which contains the bacteria, strike the mural endocardium, strike the cardiac and papillary muscles, they can also be the sites of vegetations. In VSD, the right ventricular side of the VSD, the tricuspid valve, or the pulmonary valve would be the preferred sites of the vegetation formation. In hypertrophic cardiomyopathy, the aortic valve, the septal endocardium, or the mitral valve are the usual sites of vegetations. Look at this example where both the leaflets of mitral valve contain some oscillating masses. The vegetations are diagnosed by the presence of an extra tissue in the valvular structures or in the mural endocardium, which makes independent movement, independent of the valve motion and oscillation also. Freshly formed vegetations are, some of the echogenicity, something similar to the myocardium. Look at the myocardial texture and look at the vegetation texture. They are more or less the same. In contrast, if it is a healed or old vegetation, the echogenicity may be more. Whenever there is vegetation formation, there is accompanying destruction of the valve. So invariably, significant regurgitation accompanies the presence of vegetations. This is a patient with bicuspid aortic valve with a large vegetation hanging into the left ventricular outflow tract that causes, moderate degree of aortic regurgitation. Another example of bicuspid valve with infective endocarditis, vegetation is much smaller than the previous one. Just look at the vegetation; it is little more organized, little more, echoic. Probably, it is in the healing phase. Look at the way in which it makes independent movement, when compared to the movement of the valve leaflets. Here is an example where you have vegetation of the mitral valve as well as the aortic valve. leading to severe MR and mild aortic regurgitation. Whenever you have infection, obviously there is hematogenous spread of the organisms which can infect the adjoining valves. If someone has aortic regurgitation, the regurgitant jet strikes at the mitral valve, so you have the seedling vegetations onto the adjoining valves. So involvement of multiple valves is not uncommon. In another example of rheumatic heart disease, mitral stenosis, doming mitral valve, fixed posterior leaflet. But if you look at the AML vegetations, it's making independent movement. Diastole, it moves into the LV, and in systole, it flings into the left atrium, and there is accompanying severe MR confirmed in apical four-chamber view. Another example of rheumatic mitral valve disease, look at the AML vegetation moving, making to and fro movement in phases of cardiac cycle. In contrast to what you saw in the previous instances, this also belongs to someone who has suffered from infective endocarditis in the past. The vegetations are there. You can identify some extra masses attached to the valve leaflets, but the echogenicity compared with the myocardium, it is much denser. Probably, it is also calcified. This is the, healed vegetations of mitral and aortic valve. Right-sided infective endocarditis. Whenever right-sided infective endocarditis occurs, sparing the left-sided valve, consider IV drug abuse, because the common site of infective endocarditis in IV drug abuse is tricuspid valve and the pulmonary valve. You can just look at the flail anterior leaflet with the large vegetation going to and fro from RA to RV in different phases of the cardiac cycle. Pulmonary valve may be rarely the site of vegetation. Some 2-3 examples of vegetations, then in the RV endocardium. This also occurred in a patient with VSD. The vegetations are there in the pulmonary valve as well as in the pulmonary artery. You can look at the oscillating mass in the pulmonary artery. And this patient has VSD. As I mentioned, right side of the septal defect and the tricuspid valve are the favorite sites of vegetation formation in ventricular septal defects. Here is a patient with ruptured aneurysm of sinus of Valsalva. The jet was, has been striking at the tricuspid valve. So tricuspid valve was the, site of vegetation, in addition to the fistulous communication having the infected material. PDA, obviously the jet, goes from left pulmonary, from the ductus into the pulmonary artery. So again, the pulmonary valve gets infected. The pulmonary artery may be the site of vegetations in PDA. In someone with intravenous central lines, people with transvenous leads, with pacemaker, the pacemaker lead may be the site of vegetations. Tricuspid valve also may get infected. Diagnosing endocarditis in a prosthetic valve is generally difficult because you have a lot of echogenic structures, the struts, the sewing ring, and so many are there. So, picking up a vegetation like this is little unusual, but you can make it more confidently with the help of transesophageal echo. So transesophageal echo is very much indicated if you suspect endocarditis in a patient with the prosthetic valve. Look at the usefulness of transesophageal echo. Transthoracic echo shows some thickening of the mitral valve and the aortic valve. You are suspecting infected endocarditis. Look at way in which the transesophageal echo has helped nicely demonstrating the vegetation on the atrial side of the AML. Not only that, look at the base of base of AML. There is cystic lesion there. It is nothing but an aneurysm of the anterior mitral leaflet, which can also rupture and produce regurgitant jets. Whenever there is an extra mass attached to a valve cusp or the mural endocardium, the chances for it to be a vegetation are more if it is low reflectance, something like the myocardium. If it is attached to the valve, particularly the ventricular side of the semilunar valve, atrial side of the AV valve. But this is, common situation. But the vegetation can involve on both sides, one of the two sides. It may differ from person to person. Whenever the mass is of irregular shape, amorphous consistency, mobile, makes independent movement, oscillating masses, associated valve destruction and regurgitation, the likelihood of it being vegetation is small. In contrast, in someone with a mass with high echogenicity, non-valvular location, smooth surface, presence of calcification, non-mobile nature, absence of regurgitation, speaks against the possibility of a vegetation. You tend to get negative studies in a patient with suspected infective endocarditis if the vegetation is small. If it is a non-vegetant infective endocarditis, in the early phase, it may show some subtle leaflet thickening only. If the vegetation has embolized already, if the abscess is small, if the image quality is poor, you are likely to miss in spite of it being infective endocarditis. False positives, there are many, simulating structures, the vegetations of Libban sacs or merantic endocarditis, tumors, thrombi, lambal excrescence, some of which I will show examples, subsequently. In contrast to infective endocarditis, where the vegetations are large, bulky, irregular, specifically on certain side of the AV and semilunar valves, with a higher occurrence of embolization, acute rheumatic fever, small vegetations occurring during acute rheumatic fever, occurring only in the closure lines. And look at non-bacterial thrombotic endocarditis. A subtype of it is Libman sacs. It predominantly occurs in the lines of closure, the smaller ones, with the embolization being less common. Here is an example of someone who had undergone aortic valve replacement with a tissue valve a month ago, comes with fever of 1 week duration, transthoracic echo. These are the structures of the prosthetic valve. In between, you could see some bright structure. This is the prosthetic aortic valve, except that it is slightly more thickened. The mobility is not restricted. I can't see any vegetation. But if you look at the gradient, it is much higher than what was registered when the patient got discharged. It was 18 millimeter mean gradient across the aortic valve, which has quickly increased to 50 millimeter of mercury at the end of 1 month. So some problem is happening. So, blood cultures were sent, but in order to avoid delay in the diagnosis, the next day he was taken up for transesophageal echo. You could, make out abscesses. You could make out the vegetation getting attached to the valve cusp much more nicely than what you saw in transthoracic echo. So transesophageal echo is very, very essential. Even if you make a diagnosis of vegetation in prosthetic valve, you should consider transesophageal echo as quickly as possible, because it tells you about the other associated problems like abscess formation, etc., which may be indications for early surgical intervention. When would you consider surgical intervention in a patient with infective endocarditis, uncontrolled heart failure, acute severe aortic regurgitation, or acute severe mitral regurgitation, large vegetations, generally caused by staph and fungi, more than 10 millimeter. Whenever you demonstrate complications in the form of abscess, aneurysm, fistula, pseudoaneurysm, dehiscence of the prostatic valve, you should, consider surgical intervention. Here is a patient with aortic valve endocarditis. Looks very innocuous. Aortic regurgitation is not much, but look at what happens to the anterior mitral leaflet. Some discontinuity is seen in some part of the cardiac cycle, but color flow tells you that there is a distinct perforation of the anterior mitral leaflet leading to severe mitral regurgitation. So this has identified a reason for sending him to the surgeon as early as possible. Apical four-chamber view, similar way, like two regurgitant jet, the line of coaptation, and much more severe regurgitation occurring through the perforated anterior mitral leaflets. This is a patient with aortic valve endocarditis. Look at, there is some echo, free space close to that. It is nothing but an aneurysm of the mitral aortic curtain or the intervalvular fibrosa. Again, it is an indication for surgical intervention. One more example of a perforated mitral valve. You can easily demonstrate discontinuity in the transesophageal echo. Something like the windsock of ruptured aneurysm of sinus of valsalva. You see the ruptured basal portion of the anterior mitral leaflet. This is an aneurysm of the anterior mitral leaflet. This is a root abscess in a patient with aortic valve endocarditis. This tells you how the prosthetic valve sewing ring can get detached from the sutured site, the so-called dehiscence of the prosthetic valve. This also motivates you to consider early surgical intervention. Simulating, lesions, one is dense fibrosis and calcification, typical changes in aromatic valve, the predominant thickening of the leaflet margin. Some mass is attached, but it is hyperechoic. It is not moving independently when compared to the leaflet movement. So it is very likely to be the fibrotic or the calcified lesion of rheumatic process. Like that, you can get fibrinous rings, fibrinous strands, which you can simulate. The Lambel's excrescences are generally linear structures. It can embolize and produce strokes. This is another simulating condition for endocarditis. Small tumors like fibroelastoma, the aortic valve, is a closely mimicking condition. Now, apart from being helpful in establishing the diagnosis, this one I obtained from someone from US, where they use this percutaneous suction device. This is an angiovac device, which is used in sucking out the tricuspid valve vegetation in an IV drug abuser. He was considered to be a very high surgical risk patient. So at least, debulking the vegetation could be done with the help of transesophageal echo coverage or umbrella. As I mentioned in the beginning, echo has a versatile role in infective endocarditis. It diagnoses based on the presence of a vegetation or significant valve regurgitation. Remember, TE is most often required, particularly in prosthetic valve. Consider repeat study if the initial one is negative. Don't stay with the first study alone. Look for complications, root abscess, fistula, pseudoaneurysm, ruptures, etc. We should appropriately time the surgical intervention with the help of echo findings. And it also helps you to monitor during procedures, before and after surgical intervention, during percutaneous interventions for infective endocarditis, particularly the right-sided infective endocarditis. It is going to be of great use. Thank you.
Uh, Thank you, Dr. Shanmuga Sundaram, for having such an exhaustive review of infective endocarditis and showing so many examples of infective endocarditis, the real pathologies. Now, actually, the questions in the chat box you have already covered, because they were discussing about the specific findings, diagnostic findings on the echocardiography, which you have already covered very well. And then there was a question about how to identify vegetations, their echocardiographic features, and that also I think you have already had a very good summary in the slide, how the vegetations behave. So I think we have already covered those questions. I think I should thank and congratulate all the three speakers for covering their respective topics in real depth, really earnestly, and showing a lot of pathology by the echo clips. I think that was a very wonderful educative experience. I also thank the Glenmark team for arranging these 6 sessions, and also the API for collaborating and disseminating the eco knowledge among their delegates. I request all the delegates who had been logging onto these sessions over the last 6 months to give a feedback to the Glenmark team what they would like to have in the next year. Okay, whether they would like a one notch higher involvement, one notch higher standard of presentations, so that all our team of expert panelists also and the lecturers can then cover so many other aspects of echocardiography, and probably one or two notch above what we have presented as the basic echocardiography. Thank you.
Thank you. Good night.
Thank you. Thank you so much, sir. Thank you so much, Dr. Nitin. And I would like to thank you, each speaker. Thank you, Dr. Devika. Thank you, Dr. Shanmoga Sundaram and Dr. Algeson. And thank you so much, Dr. Nitin, for having an expertise and expert moderation. Just to inform you all, currently we are having 1100 attendees as live right now. And I would thanks each one of you for coming online and giving your precious time. I hope this entire 6 session were very insightful for each one of you, and we are very, very delighted. And as Dr. Nitin has mentioned, that we would love to have all of yours feedback, and we would like to take you all ahead for the next financial year for the one notch up session. So thank you all so much, and hearty congratulations, sir. We have successfully completed our first session, and we are really grateful for giving us a fantastic idea and directing the entire course. And all the speakers from first session to here, we have enrolled more than 20 speakers for including all the 6 sessions, and we are really grateful. And thank you, Dr. Nitin, because on your just for you have mentioned and everybody have come on board. So entire Glenmark team is very grateful to you, sir. Thank you all the speakers. We are really grateful, and thank you for the insightful session. And I hope we see you all again for the next one notch up session.
Sure.
So yes. So thank you all the delegates, and thank you,
Bye.
sir.
Good
Have a
night.
good night, sir.
Bye.
Yes.
Bye-bye.
Yeah,
Night,
thank you.
everybody.
Thank you.
Thank you.
Thank you, sir. Thank you, ma'am. Thank you, team. Thank you, Dr. Shambhu. And thank you, technical team.